Hello everyone. So myself, Dr. Shivam is going to review an article that is randomized triple-blind parallel controlled trial of transcranial direct current stimulation for cognitive rehabilitation after stroke. The article is published in Journal of Visualized Experiments, JOE, in 2025, and authors of the article are Gonzalez Rodriguez et al. Moving to introduction, as we all know, stroke is the leading cause of disability in the world and especially in adults. And it's one of its complication that is hemispatial neglect, that is most common attentional impairment following stroke occurs in 25 to 50% of stroke patients, and that also up to 80% in individuals with right hemisphere stroke. Hemispatial neglect implies difficulty in attending contralateral hemifield to injured area. It can be allocentric or agocentric. Moving on to next, conventional therapies such as central location optokinetic, caloric, and vestibular stimulation neck vibration have limited long-term benefits. So the TDCS direct current stimulation, which is a novel treatment, is a non-invasive neuromodulation technique able to modify cortical activity by inducing weak electrical currents in brain leading to neuroplasticity. So, based on inter-hemispheric rivalry model proposed by Kinsborn in 1977, uh, he stated that in basal state, both hemispheres constantly inhibit each other, and hemispatial neglect is caused by imbalance between them. So, intact hemisphere becomes hyperactive as damaged hemisphere is not able to inhibit activity of preserved hemisphere. Here comes the role of cathodal TDCS, which can induce cortical inhibition, reduce hyperactivity of intact hemisphere, and restore interhemispheric balance. HT-TDCS provides more focal stimulation than conventional TDCS. So, aims of the study is to describe a parallel randomized triple-blind clinical trial protocol to know its focal TDCS, HD-TDCS is more effective than conventional TDCS, and to evaluate feasibility and preliminary effects using a pilot participants. Objectives of the study is to combine cathodal TDCS with computerized cognitive rehabilitation, assess changes in hemispatial neglect, cognitive performance, functional independence, and to establish safety and feasibility of the protocol. The hypothesis stated in the study uh, are cathodal HDTDCS over the left posterior parietal cortex combined with cognitive training will reduce hemispatial neglect and improve functional outcomes in post-stroke patients. Moving on to study design. Study design is parallel group randomized triple blind study in which patient, therapist, and outcome, all the three assessors were blinded. It is a sham controlled study, registered clinical trials, and ethically approved. So the research setting was brain damage unit of Foundation Hospitalaris Madrid and clinical neurorehabilitation. Sampling technique used in the study is purposive sampling. And this sampling was done using a clinical recruitment based on eligibility criteria. It's a single participant study, pilot study, designed for future larger RCTs. Inclusion criteria and exclusion criteria. Inclusion criteria involves right hemisphere stroke, ischemic or hemorrhagic 3 to 12 months of stroke patients. Age is 18 to 89 years. Neuroimaging study, uh, and absence of previous stroke. Barthel index stroke greater than 5 in the items of transfer between chair and bed. Right-handed manual dominance, neglect scores on at least 2 or the test administered for the assessment of visuospatial neglect, and informed consent by the patient or legal guardian. Patients with dermatological patient problems such as psoriasis, dermatitis on the scalp or face were excluded. Presence of implants or metal parts in the head excluding fillings, pacemaker, medication pump, stimulations, vagal, cerebral, transcutaneous, and ventriculoperitoneal shunts or aneurysmal clips. Presence of previous stroke, any neurological disease other than stroke, MMSE scores under 24, significant language deficits, history of alcohol or drug abuse, pregnancy or suspected pregnancy. Any of these patients were excluded out of the. Moving on to randomization and blinding, computer-generated random allocation was done in this study. It was active versus sham stimulation study and the triple-blinded study design. In intervention, TDCS was given. Device was 8-channel HT TDCS device. Intensity was 2 milliampere. Duration of 20 minutes and 10 sessions were given in 2 weeks. Montage was cathode at P3, left posterior parietal cortex, and return electrode was C3, CP5, CP1, PZ, PO3, PO7, and P7. This is the TDCS device kit with 8-channel TDCS device and along with the neoprene cap used for guided placement of electrodes based on the EEG system. So these are the points which were chosen for the application of TDCS. And another cognitive rehabilitation was given, which was based on computerized neurophysiological training. 4 tasks per sessions were given of 7 minutes each task. Total cognitive training time was 30 minutes per session, and it was performed concurrently with TDCS. Uh, these were the tasks given during the session. Various tasks such as hidden letters, sum of figures, letter soup, finding matching shapes, copying letter matrices, little Wolverine, finding missing numbers, comparing text, text comparison, sum of figures, little written, search for consecutive stimuli. These all were the tasks that were made to perform by the patient in 10 sessions. 11 outcome measures were used, out of which 9 were cognitive and neglect test, that is line bisection test, Bell's test, cancellation test, MBPT4, digit span, BTA, face test, drawing copy test, and MMSE. And 2 were functional skills, that is Barthel index and Catherine Bergego scale, CBS. So the results showed the improvement in 6 out of 13 variables. There was a significant improvement in Bell's test, cancellation test, line bisection, and MBPT4 and Pathal index scores. And no serious adverse effect was noted about the treatment. Good patient compliance and tolerability was there. This is the result of neurophysiological and functional assessment before and after the intervention. So in the graph, the higher values indicate positive change, except in the line bisection test, where improvement is represented by lower scores. And this graph shows the positive score indicates positive change, and the negative scores are negative changes or decline in score. So in discussion, combined HD-TDCS given along with cognitive training shows domain-specific benefits with greater improvements in neglect-related attention tasks and limited effects on general cognition, attention process, and working memory. With reduction is observed in the performance in VTA, faces, direct, and inverse digits. Therefore, HD-TDCS provides better focality and potential longer lasting effects. These findings were supported with previous neuromodulation researches. So the study concluded that protocol is feasible, safe, and well tolerated. Combined interventions may improve hemispatial neglect after stroke, and it is suitable for larger randomized controlled trials. There were some limitations reported in the study, such as it is a single participant pilot study, and there were no long-term follow-ups, and it is limited in generalizability. In future, larger scale RCTs can be done. Comparison with conventional TDCS can be done. Long-term outcome assessment can be noted, and even lesion-specific analysis can be done. These are the references. Thank you.